Welcome to ANA Investigates, a monthly podcast covering the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. This month we'll have an episode that's more about social science than about neuroscience. We'll address implicit bias, explicit bias, and our ability to change each of our biases. I'm speaking with Jim Siegler, Assistant Professor of Neurology at Cooper University Hospital. Hi, Jim. Thanks for joining us.
Happy to be on the program. And I'll just say that while the topic of bias, like you said, is more about social science than neuroscience, it is such an important and a sensitive subject for us to recognize as clinicians, researchers, and as educators. For the show this week, I was lucky enough to speak with Dr. Allison Willis about the topic of bias.
My name is Allison Willis, and I am an Associate Professor of Neurology and of Epidemiology.
Dr. Willis works at the University of Pennsylvania Perelman School of Medicine, and I've had the pleasure of working with her for the past couple of years. She's a renowned expert in big data research and is a translational epidemiologist in Parkinson's disease who has published on disparities in neurologic disease and underrepresentation of minorities in clinical research. For today's program, I got to chat with her about the topic of bias. And to be clear, she doesn't consider herself an expert on bias, but she is tremendously thoughtful about the subject, and she's been involved in research evaluating the biases inherent to healthcare disparities. So in talking to Dr. Willis, I first wanted to better understand what is implicit bias.
Implicit bias is bias that occurs in your subconscious mind. It's an attitude or a perception that you have that is related to, say, another person's ethnicity or their race, their age, their gender, or perceived gender. And it's that subconscious feeling or connection with your view of them that can drive how you treat them, how you interact with them, how you interpret what they say, whether they're smiling, whether they're performing to the standards that you accept or are in agreement in, and implicit bias focuses on subconscious attitudes and perceptions of other people.
Jim, remind us, how is implicit bias distinguished from explicit bias?
Well, implicit bias reflects a subconscious attitude toward our perception of others, whereas explicit bias is your recognized open beliefs and stereotypes. And it's important to clarify that while they're different, the two often coexist in an individual.
In theory, implicit bias is that which a person is not aware of. It's their subconscious bias. However, it's important to realize that implicit bias and explicit bias often coexist in an individual. So when we're trying to measure or think about implicit bias, we sometimes are really measuring explicit bias, the outward stereotypes, the outward negative feelings about an individual based on their outward characteristics that drive negative behaviors or treatments of them.
And how do we try to measure implicit bias?
It's a great question, and I asked Dr. Willis to explain one of the major ways that we try to measure implicit bias, a test that's called the Implicit Association Test, or the IAT.
The implicit association test is a psychometric assessment developed by researchers at Harvard, and it is perhaps the most widely known or widely used measure of implicit bias. And the test comes in many forms. It can be taken online, and it examines how quickly you are able to react to associations of a sex with a positive word or a person of a particular race with a positive word. And by examining the difference in your reaction times between, for example, white race and black race and the word good, the developers think that the test measures subconscious bias.
I'll jump in here and say that Dr. Willis recognizes the IAT is not a perfect tool for assessing implicit bias, and there's a lot of controversy about the usefulness of this test.
researchers have found that your score on the test can change over time. So the developers of this test admit that a single test episode is not sufficient to let you know whether you have implicit bias or not. And myself, when I've taken the test, I found that my score and the direction of my bias could change depending on when I took the test, or it changed over several assessments of the test. So the test is meant to be used with the scores interpreted in aggregate form, meaning you take the test several times or you take it over time, and the trend lets you know whether you have implicit bias or not. Similar to like measuring your blood pressure. So one high blood pressure measurement doesn't necessarily mean you have hypertension, but if you are consistently hypertensive or consistently have high blood pressure, then you are. This test is meant to be measured or interpreted that same way. One of the troubles with this test is that, again, it doesn't account for explicit bias. So because implicit bias and explicit bias, or just like frank racism or sexism, tend to track together, doing something that would improve implicit bias doesn't necessarily mean that you will achieve the outcome of reducing bias, especially if a person who has implicit bias also has explicit bias, and especially this day and age is no longer afraid to use it.
The other thing that Dr. Willis explained is that over time, people can perform better and better on the IAT, but we don't think that this means that they actually hold less implicit bias.
The IAT is kind of our best measure of implicit bias, but what we think is happening is that we're just training people to take the test better, to like beat the test.
So is it possible to change our implicit bias?
That's a great question. Dr. Willis says that as far as we know, we cannot change implicit bias. That being said, you can try to change your own explicit biases. So while measuring implicit bias is certainly interesting, Dr. Willis says that we should focus more on recognizing and addressing explicit bias.
Well, I would encourage listeners to understand that implicit bias exists, and B, to also focus on explicit bias and to think about ways in which they may be choosing someone for reasons that aren't objective, or that their behaviors may demonstrate a preference that can't be backed by objective measures. We can see research studies that show that explicit displays of racism or sexism drive behaviors much more strongly than subconscious or implicit bias. And so I tend to focus more on recognizing explicit bias than implicit bias.
Jim, how did Dr. Willis become interested in implicit bias?
Like I mentioned earlier, Dr. Willis is a translational epidemiologist, and she wears many hats at the University of Pennsylvania. Throughout her career, she has explored health disparities in the outcomes and management of patients with Parkinson's disease.
And in wondering or studying why someone might develop Parkinson's disease or how to improve outcomes in Parkinson's disease, I found that a large proportion of the population with Parkinson's disease wasn't receiving state-of-the-science or even standard care for Parkinson's disease.
She wondered why this was, and she found that there were differences in the quality of care individuals with Parkinson's disease were receiving.
So specifically, we found that older adults with Parkinson's disease, women, and minorities and rural-dwelling individuals with Parkinson's disease were less likely to have state-of-the-science or standard care for Parkinson's disease, and that associated with worse outcomes like falls, institutionalization or nursing home placement, hospitalization. These were negative health events with true cost to the individuals, their families, and true cost to our healthcare system, which were preventable in theory if the person had been receiving guideline adherent care.
The disparities that Dr. Willis describes in Parkinson's disease also plays out in other types of neurologic disorders. For example, in some of my own research as a medical student and later in a multinational cohort study of patients with stroke, we see that patients are less likely to get a complete diagnostic workup if they are older, and they're less likely to receive standard of care therapies if they're Black. And we think that bias is a component of why these disparities exist. And for the educators in the audience, bias plays out not only in patient care, but also within the academic community. I've come across several studies that report male surgery residents have 10% longer recommendation letters from their supervisors when compared to female surgery residents, that LGBT trainees have been perceived by faculty mentors to be less skillful in providing medical care, and white medical school applicants are preferred over equally qualified Black applicants.
So clearly we need strategies to address bias.
Absolutely. And I asked Dr. Willis what we can do to address bias within our own academic leadership.
One of the things is increasing the number of people who are underrepresented in positions of healthcare leadership. But along those lines, it's also important to make sure that those who are selected for leadership are receiving the training and exposure and experiences necessary for them to be helpful. A decrease in promoting people into positions of leadership based on familiarity or shared past experiences will go a long way towards diversifying our healthcare leadership teams.
Almost universally across academic hospitals, trainees and faculty are required to complete some sort of training regarding diversity awareness. Dr. Willis said that there was relatively little data to support that these types of approaches can alter our implicit or even our explicit biases. Instead, they may just be teaching us how to hide our explicit biases from others. And those hidden biases can still lead to behavior that promotes inequality in the workplace. So we probably need to make more of an effort ourselves to identify and course correct these biases, not only to provide the best medical care to our patients, but also to build a safer and a more respectful workplace.
Great. Thanks so much, Jim.
My pleasure, Adeline.
Again, that was Dr. Jim Siegler, Assistant Professor of Neurology at Cooper University Hospital, who spoke with Dr. Allison Willis, Associate Professor of Neurology at the University of Pennsylvania Perelman School of Medicine. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us. To learn more about today's program and to access more of the incredible content produced by the ANA, check out myana.org. Adeline Goss is our host. Our producers are Romer Giucaden, Adeline Goss, Michael Halstead, Megan Ritchie, and Jim Siegler. Our editor is Jen Hurley. If you'd like to learn more about receiving CME credit for listening to ANA Investigates, visit myana.org and navigate to ANA Investigates under the Education tab. For more information not covered in today's program, check out the official summary of this episode, published in one of the ANA's journals, the Annals of Neurology or the Annals of Clinical and Translational Neurology. Copyright, the American Neurological Association.